Hello, welcome to the 2018 JHN annual meeting. My name is Margaret Brown. I'm the Director for Population Management. I've been with the organization for almost 9 years and for the Jackson Health Network for the past 5. A special welcome to our first-time guest, and for those of you who are not so new to this, welcome back. We hope that today will be a valuable use of your time as you learn all about the great work we are doing here in JHN. Today's presentation will be about 45 minutes, and if you have questions, I ask that you submit them via the website or that you contact your provider servicing representative. Here's our agenda for today. Our speakers will be myself, Dr. Ray King, and Pamela Wyatt. I would like to start off today with a patient story. This is an ongoing story, but I believe it shows a clear depiction of some of the work that we're doing through care management. This is a story of a 55-year-old gentleman who was discharged on the 8th of December with a COPD exacerbation. He was homeless and had no transportation, and his discharge plan, which was coordinated by inpatient case management, consisted of a stay at the Colonial Inn through the end of December. Upon discharge, he was contacted by a transition coordinator who is a member of the JHN team, and we were able to assist him with his Medicaid, as which we found out he was out of state, and it made him ineligible to receive any type of services. So the transition coordinator facilitated the transition of his Medicaid from one state to Michigan. We also brought on a 211 navigator onto the care team, as this individual had multiple social needs, and they were able to facilitate that, of which one of the primary needs was his housing. Following this, the transition coordinator was able to set him up with an appointment with his primary care physician, and then also made the transition to a care manager who also was able to address his long-term needs. The care manager assisted with home health, medications, and durable medical equipment. This is definitely a success story that is ongoing.
Thank you, Margaret. And hello, everybody. I'm Ray King. I think you probably know who I am, but last fall's reminder, I transitioned some of my roles to Dr. Mark Smith, so I'm no longer your Chief Medical Officer here at Henry Ford Allegiance, and I'm concentrating on Jackson Health Network and our population and community health efforts. And so we'll get rolling here. So Margaret shared a patient story with you, and I wanted to share a story that I heard recently about an opportunity to improve what we're working on. So heard from a primary care doctor here in town that they were working past 5 o'clock in their office, and they saw a patient who looked like they had a significant possibility of having a pulmonary embolism. And they wanted to get an imaging study done, a high-tech radiology procedure, CT angiogram, and found out that in order to get that done in the evening, get it done urgently, emergently, that they were going to have to send that patient through the emergency room. Now, that's an opportunity for us to improve, because not only was it a bad experience for that patient because they had to spend time in the emergency room when they could have just gone to radiology and had the tests done, there's extra cost involved with going to the emergency room and spending that time in the emergency room. And as I talk about our new value-based products this year, we, meaning you and us, we're all responsible for that cost of care, and it's going to impact our own reimbursement. So think about that story, and we've already worked through the process to improve that so that that scenario doesn't happen again. But those are the types of things that you folks see every day. You need to let us know about, because there's multiple opportunities out there for us to do things better, differently than we have in the past. So what's different at this point in time? In the past, what you saw, our incentives, the extra dollars that we had to distribute to you, were really based upon quality measures such as prevention, screening for chronic disease management. We had dollars coming in for that. Fewer dollars these days coming in for that, and really those quality, or what we call our clinical integration measures, or CI measures, those are just that's just the fundamentals that we have to do to be able to participate in gain sharing or risk sharing models. And the dollars that are going to come in to be able to distribute to you for the work you're doing, the behavior changes that you're doing, the things you're doing to change how your practice is working, those dollars are coming in based upon us saving money. And so, but for every dollar we save, if we do the CI program better, we get to keep a bigger percent of that dollar that we save. So we still have to continue to work on all of those things, and we'll get more to that later. Why is this significant? The vast majority of the 90,000 patients that we take care of through our Jackson Health Network products that we have in place, our contracts, are at least have upside potential, but now this year we have actually some downside risk, and there's the potential to actually lose money on certain contracts if we go over our budget, and we'll get into more detail. Our primary care docs, our ER docs are already seeing some changes, that's seeing some improvement. We are having slightly fewer admissions to the hospital, fairly significant reductions in the amount of ER utilization, but we still have a long ways to go. So one example, and you're going to see some examples later from Pam, but you guys have been doing some really good work. Here's just an example through breast cancer screening. We want more of our patients to be screened for breast cancer through mammography, and other than this blip that we see when we went live on Epic, which you all remember how that went, and we weren't capturing all the data at first. There were some delays in getting the data in the system. We've had a 6.5% improvement in our breast cancer screening over this time period, and those are all very positive things, and there's a lot more examples than that that we can share. Still opportunity to do better for our population, but we're making some good progress. You've seen me show this slide pretty much every year since we've been doing these annual meetings, and this now really hits home. Our model before, our financing model for providing health care was the more things that we did, the more that we got paid. Somebody came into the emergency room, and for some folks, that was a good thing from a financial standpoint because we got paid for that visit. Now we have to start shifting our frame of reference to is that a sentinel event? How did we let that person down that they ended up having to come to the emergency room or be admitted to the hospital? What could we have done different? And Margaret's going to come back on a little bit later and explain that in a little bit more detail. But just think about all those things where if it was you or your family, you would have wanted things to happen differently. And how are we going to take care of our patients, our population in a different way? So I want to spend some time talking about the value-based products, which are new this year in 2018 and are already in effect. So what's different? Cost of care, as I said previously, is now a factor. The financing model is now changing to support the care delivery transformation that we've been talking about through JHN for the last 5, 6, 7 years. And you need to care even more because, as I mentioned previously, your incentives are more heavily weighted to our financial performance. But again, the better our clinical performance is, the better we're going to do on the cost savings piece of this. I did want to talk a little bit about a health system that I think most of you are very familiar with, and that's Geisinger and some of the things that they've done where they've shown an impact of the cost of care, but significant improvements in quality. So they have something called a proven care model where, for in this example, coronary artery bypass surgery, that the employer, whoever was paying for that care, knew up front what it was going to cost them. And that's all the cost, that's all they were going to have to pay for their service, regardless of how the outcome happened, regardless of whatever happened to the patient. So, but Geisinger didn't work on, hey, how do we get the cost out of the system? They worked on how can we improve the care? How can we improve the protocols, our workflows, and all of those things? And you can see here on this slide, there are some significant improvements in complications, in mortality, in utilizing blood products, readmissions, reintubations, and such. The length of stay went down slightly, but the percent improvements in these areas actually led to a significant cost savings for Geisinger in providing the services. And so they were able to beat their targets and meet really what they needed to meet to make this guaranteed cost to the employers, the patients, to make that work. We do have our own example of this, and that's really related to sepsis care. And we are leaders within the health system. We're leaders actually within the country related to sepsis care and putting protocols and procedures. Now we have a sepsis unit on the 7th floor, and so we have standardized the care for patients coming in with sepsis. Nationally, when sepsis became something that people were really started to take notice about, nationally, severe sepsis and septic shock mortality rates were in the 32, 33, 34% range. And we were about the national average. We put in these protocols, policies, workflows, standardized the care, and our mortality rate has reduced to 16%. And not only is that better outcomes, families, obviously are happier, patients are happier, but this leads to a dramatic reduction in the cost for this set of patients. And actually, Dr. Brian Kim and Wendy Boersma, CMS had a webinar about sepsis care, and they presented nationally on the CMS webinar related to this. So think about the things you do. And here's another example on the outpatient side related to diabetes bundles. And Geisinger put these in effect. You guys have been doing these diabetes bundles now since 2011 through JHN. And what Geisinger was able to show was dramatic reductions in the cost of care for these folks with diabetes year after year after year. So getting people into these programs, and again, think about things you do. Is it diabetes care? Is it care for people with back pain? Is it care for people with heart disease? And how we can improve the processes, the workflows, the standardization for those things that are appropriate, and we can improve the quality of care and reduce the cost. So something else that we did, the end of 2016, early 2017, we pulled back together a group of employers in the community to talk about what's important to them. And what we were hearing is that they felt that they were not getting value from the payers. And so they found the only thing that differentiated the payers was, what's it going to cost me for my premium? And so one of the employers we ended up working with throughout 2017 was our own Jackson County government. They identified who they were using as an insurer was predicting a dramatic increase in their cost of their health care, something that was going to actually blow up the county's budget. And so sitting down with JHN and actually the broker that the county used, and then trying to figure out, okay, how are we going to provide the insurance company the coverage and do all of the insurance type of work, brought Health Alliance Plan, brought HAP into the equation and said, okay, how are we going to work through this? How can, what can we do to provide a differentiated benefit package for the employer, for their staff that would meet their needs and help them meet their budgetary obligations. And we knew this kind of stuff was coming way back, even in 2010 when we started talking about healthcare reform. And what we created for the county, and folks, this is your insurance product now. the county employees are carrying around an insurance card that says Jackson Health Network Select. And we work this through the doctors on your JHN payer contracting committee, the physicians on the JHN board, and they said, yep, this is something that we have to do. So when your front office sees a patient and sees this card and it says Jackson Health Network Select, this is now your insurance product. And what's different about this is something that's going to be disruptive in this market, because this is not the same as any other insurance product that's out there right now. And our goal is to fulfill the unmet employer need and create something that was of increased value to them. So we wanted to offer something other than just traditional healthcare coverage. And again, we talked earlier about aligning that financial model with the efforts to transform healthcare, because we know if we could design this from healthcare from scratch and the whole delivery system, we wouldn't do it the way it is today. Waste of money, waste of time, waste of efforts, and such. So this is something that's new. And one of the important things, that last bullet that we heard from our physicians, was there needs to be shared responsibility for cost and outcomes. And so even to the point where including the patients that you all take care of. And we heard that from you in the past, that unless our patients have some financial stake in the game, that they're probably less likely to do what it is that you're going to recommend to them. So we'll talk about this. The other thing that's unique, when the county went through open enrollment with their employees, the county was there, HAP was there, and we were there to talk about this product. And that's something that is very, very unique. So some specifics about this JHN Select Plan, Your Health Plan, is that it's a narrow network or preferred network. And we've heard this from employers in our community, is that if they can get something other than the traditional products that they've had, they're willing to work with you all in JHN and the Henry Ford Health System on keeping care within a smaller network, a narrower network, a preferred network, compared to all of, in this case, HAP. And so that Tier 1 is everybody in JHN and the Henry Ford Health System. And as I say, everybody in JHN, there's sometimes some misperception. This is the physicians who are in private practice, the physicians who are employed by the health system, and the physicians who are contracted by the health system. It's exactly the same for everybody. Tier 2 for the county members is the rest of the HAP HMO network. So, and pretty much every hospital in the state is in Tier 2 except one hospital. So the network is huge, so people don't have to go without. So what is the difference between Tier 1 and Tier 2? There's financial incentives now for the employees of the county to use Tier 1. It's going to cost them pretty much across the board double out of pocket to use the Tier 2 network compared to Tier 1. So they're going to want to come see you, and then if you can't provide that service, they're going to want you to send them to another provider within JHN or the rest of the Henry Ford Health System, and the facilities and services within our JHN network as well. So for you, continuing to drive care to that lowest cost setting that provides the level of care that you feel is necessary for your patients is going to be critical for the success. The members also, the patients also have obligation to have a PCP. And again, a PCP that's within Jackson Health Network is going to provide the best benefit package for them. Also, it's going to require, the county is going to have to help drive the patients into care management where it's necessary, and also to offer education to their employees. So we have guaranteed some rate increases to the county, but they need to help drive their members into having a PCP relationship, using care coordination, care management, as Margaret's going to talk about, and again, continuing to offer education to their employees about how to use their health care benefit better. So what are the keys to success this year? For you to remember, using in-network providers and facilities where at all possible. Henry Ford Health System for high-end tertiary and quaternary care that we can't do here. And if you're running into any barriers with that, we can help expedite using other specialists within the health system that can provide that level of care. Our goal this year is to try to reduce costs by 5%. So national data, we have been a relatively loosely managed community as far as healthcare, and loosely managed really means we cost more. We use more services here. We don't coordinate care as well as we could. There's been a higher rate of use of the emergency room, higher rate of people having outpatient procedures, of inpatient admissions, of high-tech radiology. We've already had some improvement on these things over the past couple of years, but we see we could have 5% improvement in these things every year for probably 3, 4, maybe 5 years, and really improve the cost of care, improve the care that we're providing people. And for things that people don't need, they'd rather not get them. It's a better experience for people if they can avoid having things done that they don't need to have done. The other piece where that's a key success factor is once a patient's discharged from the hospital, how do we keep them from being readmitted? How do we use our post-acute services, whether that's sending them home with home health or care management, whether they go to a skilled nursing facility. And just remember, in general, if somebody can go home from the hospital, they're going to have better outcomes than if they go anywhere else. So the other thing is access to care and making sure that we have availability of our providers when that's needed. So the new payment terms, again, we are at risk, so we have a budget. And so if we come in under budget for the year, there's going to be money that we can share with all of you for the work that you've done to keep the costs down and improve the care that's being provided. If we go over budget, there's a reserve. We have a withhold now and reserves tied to each individual physician, so you know what pot of money you have in the reserve. But we will take back, across the board out of the reserve if need be when we come under budget. And we think that we probably will have reserved enough that we won't have to have further withhold from incentive dollars that you otherwise would have earned. Also, the goal is by the end of the year we can reconcile PCP, or primary care utilization, into a capitation model. Also coming up, there's further bundle payment options that are going to be available, and we will share more of those as those come up during the year. I'm going to jump ahead a slide here to talk about, and we've showed this slide before. This is the progression that we've talked about. In the old days, it was the fee-for-service world, and then shared savings, which is the majority of what our opportunity is right now. With the county, now we're in partial capitation. We're taking some risks. 75% of the risk is on JHN. 25% of the risk is being carried by HAP. The county has risk based on if they don't engage their members in utilizing their benefit package appropriately. They're going to see their premiums go up. And again, the patients have financial risks to stay within the network and utilize services appropriately. So with that, I'm going to turn this over to Margaret to talk further about our population management and especially the care management model that we have in place.
Thank you, Dr. King. And now let's talk a little bit about population management. You can see displayed here our population management risk pyramid. The goal here is really to have prevention at our core. You can see listed at the top of the pyramid is a catastrophic event. And for us, this means, as Dr. King was stating earlier in the presentation, that we had a near miss where someone ended back in the hospital and for some reason we were not able to coordinate care appropriately. So for us, we consider this catastrophic. The desired direction on the pyramid is down, and listed to the right of it are the population management services and tactics that are in place to help us address the various levels of risk in the population. Speaking of population health is a buzzword at present, And we have found that some are using this term incorrectly, as they are mainly focusing on population health care in the event that they are focusing more on the care provided to those who are sick. So, in a sense, the subpopulation. At JHN, our focus is truly on the entire population served, and this is where we apply risk-appropriate level interventions. And these are listed to the right of the pyramid. Let me explain a little bit about how this looks like for us in Jackson Health Network. I've already explained the catastrophic event. For this, we do have transition coordinators who help to facilitate a smooth transition from inpatient to outpatient, and they follow the member for 30 days. For our care management program, we are looking at high-risk members who typically fall within the top 4 to 5% of the population. These are members that have multiple comorbidities and that are very complex and have multiple social determinants of health needs. At the very bottom of the pyramid, we have our low-risk population, and this is where we have our health management programs inclusive of It's Your Life and our health coaching program, our tobacco cessation program, and other things of that nature. Really, for our chronic disease, where we have disease management, this is where we need your help in 2018. Our outpatient nutrition counseling services and the Diabetes Education Center are part of population management. We've restructured these services and are actively reviewing our processes in Epic and assessing how to make these points of service more meaningful to you and your patients. This is ongoing work for us in 2018. We really value your feedback. Also coming in 2018, there will be a more concentrated effort around addressing social determinants of health at the practice level. And as many of you know, this is something that's already taking place at the practice manager meetings as well. Comprehensive care for us means that we are not just looking at medical issues, but also impacting the social issues that have a significant effect on a person's life and well-being. Not every person will need a care manager, but they may need housing assistance or utility assistance with transportation or food. Helping to address these components will ultimately help a person to access care and reach their goals. So some successes from 2017, inclusive of 100% of primary care practices, either through JHN services or having hired their own, are all using a care manager. For JHN, we went from having a care manager in 4 practices to 34 practices in 2017. And for each of those practices, we had to learn different workflows, communication, culture, and reporting needs of each practice. So a significant undertaking, and kudos to the team. We also work through multiple payer systems, and each of these have their own requirements as it comes to care management. So streamlining those services across multiple payers was another effort that we had great success in for 2017. In terms of billing care management codes, we have vetted these and have them set up in Epic so that we are compliant with billing. Payers impact how this is done and who participates in care management. So understanding this piece of how to bill is pretty critical for us and also is connected to reimbursement. So what can we look forward to in 2018? For care management, Dr. King referenced earlier about the employer-based program. For us, we're looking at the difference between practice-based and employer-based and trying to figure out how can we have the plethora of services that are offered through population management be meaningful to you at your practice or through your patients' employers, where care is also heavily impacted as well. So we're looking at how to provide tobacco cessation counseling, health coaching, care management, all those types of things to local businesses. Our role in these partnerships is consistent, and it aligns with our strategies for population management, inclusive of identifying subpopulations, applying appropriate risk level intervention, coordinating care, improving outcomes, and optimizing efficiency and revenue. Our goals for 2018 are truly a reflection of your feedback from 2017 and are inclusive of providing engagement to our providers in the practices, looking at standardizing our reports, and then also figuring out how we can provide outcomes-based results to you that are meaningful and can also help you in your practices. At this point, I will turn it over to Pam.
Hi, my name is Pamela White Elkins. I'm the Manager of Clinical Performance for the Jackson Health Network. I've been in this role for almost a year, and I've been working in the healthcare industry as a performance improvement leader, data system analyst, and leader of a service line. I've also had several years of experience in the manufacturing industry in the areas of quality and improvement, process excellence, and customer service. The provider servicing team is in place to support the work of the network, accomplishing the goals and supporting the strategies for each year. In 2017, we made some changes to job roles to support the work of the projects with project management and improvement with basic Lean Six Sigma training. The provider servicing team now has practice and transformation specialists. In 2017, the network was able to maintain several of the performance metric levels from 2016. A few metrics had significant improvement, like prediabetes screening and retinal eye exams. The overall community score was 48.28%. 4 metrics were removed due to data capture issues, and the targets were revised to reflect the targets from 2016. This data reflects a cutoff of 1/3/2018, and we eventually ended up cutting off the data on 1/12 of 2018. Every year, the network provides physician participation standards. These standards have been consistent for the last few years, with the only changes for 18 being additional expectations that providers meet with the practice transformation specialist at least quarterly. This picture of color provides a view of the different opportunities that exist either through the JHN CI program or payer-specific initiatives. As a network, we will make sense of this complexity. Consider the dollars available to the network within a given year. This pie chart is a depiction of the estimated dollars by payer. In the future, the largest opportunities will potentially come for performance of the ACO or affirmant and could equal over 50% of the incentive opportunities. As Ray indicated earlier, the industry and payers are putting more weight on meeting cost targets versus quality, as quality is assumed. And higher percentage of incented dollars will be tied to cost targets. And this could also result in a loss of dollars if cost improvements are not met. Monthly rounding will be accomplished with the practice transformation specialist and will include scorecard and dashboard reviews, identifying opportunities within the CI and payer programs, and action planning that supports the priorities and tactics identified for each practice. In 2017, we worked with care management team to understand the payer lists and look at system support for tracking services provided, as well as how to bill for those services. We have also begun accessing not only data within Epic and Compass, but payer claims data to provide information regarding cost, in-network utilization, and service utilization. And finally, there will be regular communications from JHN and JCMR that support the priorities and needs of the network, as well as meeting and having collaborative discussions regarding the tactics for achieving the network goals. In 2017, the network changed from triple aim to quadruple aim. The 4 aims are improved population health, satisfied patients, satisfied providers, and reduced care costs. From the aims and guiding principles, our goal was to create some action areas. The action areas are purposed to help organize the work and led us to identify specific tactics that would help us achieve our goals and aims. The action areas are population management, transformation of care delivery, performance management, and information systems. To illustrate the efforts of the network that align with the quadruple aim, we have organized the tactics into levels and categories. At the network level, there is work being accomplished around the 24/7 call center redesign that includes looking at after-hours expansion and an emergency department diversion protocol. There is also a group looking at leveraging virtual care through telehealth, e-visits, and virtual visits. In January, we held a practice manager meeting and collected feedback from practice managers and other practice employees about tactics that would align with a quadruple aim. We identified the potential tactics that aligned, and practices gave us their feedback. The blue underlined items are the ones that were prioritized based on that feedback. We have identified the items to focus on at the network and practices. Now Dr. King will reflect on what providers can do and how to support our goals for 2018.
Hi, I'm back to help wrap this up, and hopefully this has been useful information for you tonight. I just want to hit the high points again for you before we're done with this. I think the most important take-home message tonight is that all the things that we've talked about, our new contracts, the care management, and even our CI program, as Pam was just talking about, is that if we don't do this and do this well, there's other people, other entities disrupting the market that will do this instead of us. And so you've heard about the Berkshire Hathaway, Amazon, JP Morgan wanting to get in this field. We're seeing mergers of the big payers with pharmacy chains and such that want to get into this marketplace. So if we don't do this and do this well, somebody else is going to be in and do this. I do want to share a very quick story about care management that's very positive, and Margaret had shared stories previously. Just heard this story recently. One of our providers actually wrote an email wanting to thank the system for having a care manager available to her patients in her practice. What had happened? She had a patient with multiple chronic diseases who was always on the brink of having one of these, if you remember back to the pyramid, one of these catastrophic events. Lot of problems, and identified that because of the level of risk that this patient had, and the physician in her office identifying further risk, getting care management involved right away. And the risk was this person was at risk of losing her home and becoming homeless. And her chronic diseases were such that if that happened, she would have truly had a catastrophic event, the very least in the emergency room, but most likely an acute admission. And so because of this, the care manager was able to identify some housing resources within the community. We're able to get this patient, this person, to a financial institution that was willing to work with her to refinance her home so she did not become homeless. Those are the kinds of things that happen at the tip of the pyramid that we can prevent, that can avoid these. And again, back to my ER slide, these types of things, which I would call sentinel events. How did we let our patients down? So again, to wrap up, what do we need to do to be successful this year? We still need to do extremely well on our clinical integration program, our bundles, our prevention, our screening, our chronic disease management. We need to nail those. And so as our provider servicing reps come out to your practices and work with you, how can we help you with your workflows and things to improve that? Care coordination, as we've talked about, is extremely important, especially as we get to the tip of that pyramid with your patients. So identifying those folks and working with us is very critical. You as providers attending some of our practice rounding visits so that you can hear and that you can be in the loop and you can help get your practices fired up to remind them how important this is, and keeping them and yourself engaged. And any of the provider training programs that we may have this year. So just remember, emergency department visits, what can you do to keep your patients from going to the emergency room? Busiest days in the ER, Monday is the busiest day. People have saved their problems up all weekend, and sometimes those have gotten worse because of the weekend, but oftentimes they call on Monday and they hear that your offices are just too busy and they're going to have to go to the emergency room. Inpatient admissions. Once they get to the emergency room, they're more likely to get admitted. Or we didn't care manage them properly. We didn't identify these people as being at highest risk. And so the other thing is sometimes it's just, wow, this is really complicated. It might just be easier to put them in the hospital. How can we work together as providers in a health system and your Jackson Health Network to say, hey, how can we get our heads together and manage this in some other way than maybe we have in the past? The post-acute care, as I mentioned, do they really need to go to a skilled nursing facility, a rehab facility? Or that patient who just had a joint replacement, would they rather go home anyway? They're going to have as good or better outcomes. And so, how can we help transition people home as much as possible? And just remember about the high-tech radiology and think about, gosh, do I need an MRI? As a primary care doc, is that something for me to order, or should a specialist order that if it's really necessary? So we're going to be doing some work and even putting some things within Epic that might help with some clinical decision support. Other things that we have coming this year, is touched on, and we'll get more out, are these virtual visits, like being able to use Epic. My chart's just wonderful, and people who have used it just think it's fantastic. And how can we build other things into my chart to be able, so your patients can access you in different ways? And we're working on our contract so you can get reimbursed for some of these alternative visit types. So there's more coming on that. And so helping to improve access will help keep people in the system. And obviously, you can't ask me any questions because this is a video today, but we do want to thank you for taking time to watch this video and being part of Jackson Health Network. But please get a hold of me if you think of anything that can improve the way we provide care, improve the quality, the experience, reduce the cost. We'll all be more successful. And we've got a different level of engagement with the employers in this community than we've ever had before. And they're looking to us to help them with some of the problems that they're having related to their benefit packages. And the feedback we're getting from our physicians who are on the JHN board and on the committees is that this is stuff that we can do, and it's very important. And so we'll continue to work with you on creating better products that continue to have your name on them, like our product with the county. So thanks for the time again, and just get in touch with me if you need anything or have any ideas.